Hi there, and welcome. My name is Jeff Bell, and on behalf of our Deconstructing Stigma team, I'd like to thank you for joining us today. Our focus for this session, addressing OCD in kids and teens. And to that end, we want to provide an in-depth look at effective treatment approaches. While OCD is highly treatable, especially when recognized early, families often have a lot of questions about what effective treatment looks like, what options are available, and how to find the right care for a child or teen struggling with OCD. Let's get some answers from an expert, specifically Dr. Lisa Coyne. She is a licensed clinical psychologist and prolific author and popular speaker on the topics of anxiety, OCD, and parenting. She is an assistant professor of psychology in the Department of Psychiatry part-time at Harvard Medical School and an internationally recognized acceptance and commitment therapy trainer. Lisa, thanks as always for loaning us your expertise.
My total pleasure to be here. Nice to see you, Joe.
Well, I want to start with a brief overview of what OCD is and is not. Can you walk us through the very basics?
Sure. So OCD stands for obsessive compulsive disorder, and it is a disorder characterized by individuals having obsessions or recurrent intrusive thoughts or experiences like images or sounds or urges or a sensation of incompleteness, of doubt, uncertainty, etc. Right? And the experience of those leads to significant distress. The C stands for compulsions or rituals, which are behaviors that individuals do to neutralize those obsessions, right? Now, rituals or compulsions can be observable. You can see kids doing them or teens doing them, but sometimes they are mental rituals, right? Or thinking rituals, things that kids or teens might say to themselves or do or visualize or rehearse in their minds or ruminate about that we can't see, right? Either way, the function of those types of behaviors are to, again, neutralize, fix, make better, even if it's just for a brief time, the compulsion. And this is a disorder when it causes significant distress and functional impairment, which means difficulty functioning in multiple environments, like at home, might cause distress or conflict. At school, might disrupt peer relationships or academics, or in any other place a child or teen might be in their lives.
You have done a lot of work in the field over the years, working with children and teens. Have you found many distinctions in the approach? And we're going to get into that approach, but have you found distinctions between the treatment approach, for example, for kids and teens versus adults?
So the treatment approach for kids and teens is the same as treatment for adults. And the best treatment and the most evidence-based effective treatment is called exposure and response prevention. Now, that being said, how we implement that treatment looks different across kids, teens, and adults, where for children, we might be more playful. We might also engage parents as coaches in a more structured and systematic way. With teens, we would also engage parents, but perhaps more in a collaborative way so that they could support their child's growing autonomy and independence in learning how to navigate the condition and engage in treatment on their own.
So, before we dive more deeply into that treatment process, which we certainly will, let's
Mhm.
talk a little bit about how parents might identify some OCD challenges in their kids and or teens.
Right. So, this is a great question. How do you know if your child or teen has OCD? So we all know that little kids, for example, are all about rituals. For example, I need to be put to bed and I need a kiss on both cheeks and I would like a bedtime story, right? And that's a very normal thing. So when you start to get concerned, that concern might arise because those rituals that you see are developmentally inappropriate. Similarly, those fears that the individual might have, the child might be developmentally inappropriate. So, for example, if you have a teenager who is dealing with a fear that perhaps there's someone going to come and kidnap them, in their house. There's a burglar or something like that. That's really kind of a fear the younger child might have. And we're not talking about kids in contexts that are unsafe if they are living in neighborhoods that are violent, right? This is without any experience or actual lived experience of that. And so you might think about those things and notice that. And the other hallmark of this disorder is when you have kids who engage in rituals, if they really can't function very well, if those rituals or the ability to carry them out to completion is disrupted, they might get very upset. They might get very anxious or sad. They might escalate in their seeking of reassurance. They might even get aggressive or destructive. That is a sign that OCD is afoot.
Can you provide some basic structure for what behaviors might look like beyond those sort of tendencies that you've just talked about? What might
Mhm.
some of the outward compulsions be that a child engages in that would be flags for parents and or their teachers?
Sure. So, a common one that parents and teachers see is reassurance seeking. Did I make a mistake? Did I say this thing? Do you still love me? Is it safe? So asking questions like that, is this clean? Etc. So you might see something like that. You might see an insistence on having things the same or even or um, in the right places. That's another example. You might have an insistence about the way things are washed or cleaned, who gets to touch things, etc. And OCD, there's so many different ways OCD can present. These are some of the ones that are more common that you might see. Um, Difficulty handing in assignments because they're not perfect, because reading or rereading has to happen. Difficulty getting through tests. And this often gets mistaken, incidentally, for executive functioning deficits, but it can really be OCD if it's the person has to make sure that that answer is right or has to read the question multiple times and then they run out of time on a test or they don't hand in that assignment because there just wasn't enough time to check it sufficiently, right? So those are some of the things that teachers might see.
In terms of addressing all this, what are the first steps for a parent that might be concerned that their child is exhibiting some of these forms of OCD?
So the first place I know that probably parents are expecting me to say, go to your pediatrician, but, and that's not a bad idea. It's just that pediatricians do not in general have specific training on OCD. I heard an estimate from medical schools about how much time is actually spent on learning about OCD, and it's like minutes. It's not a
Oh,
long time at all. Yeah. So where I would say to start is to go to the International OCD Foundation website, which is iocdf.org. And they have specific content there for both parents and teachers that you can look at that will be an excellent, excellent doorway to guide you in what is OCD, how does it present, at what age does it start, usually the teen years, by the way, but sometimes in early childhood as well. um, what can you expect to see? What are evidence-based treatments for it? And how do you identify a competent provider as well as lists of competent providers that you can access? So it's really a one-stop shop um, to really help you learn more about this. And it's free, so you can just
yeah.
go and check it out and find out. It's a wonderful resource.
And as you said, there is so much content that's directed specifically at kids and teens
Yeah.
in terms of OCD, which is an important subset, obviously.
Mhm.
Let's talk a little bit about the treatment process itself. And maybe you can start by helping us understand the science of what we're trying to do with treatment. Well, what are we trying to
Right.
do?
Right. So the treatment with the strongest evidence base is called exposure and response prevention. And it's been around for decades. So it's a really well researched treatment. And in general, how it works is individuals are given a lot of education about what OCD is, how it works, and in child-friendly terms, right? Like your brain is having a hiccup. and it thinks lots of things are dangerous or scary. And so you're engaging in these behaviors, these rituals to fix that. And you're just doing the best that you can, right? We're going to teach your brain how to do things differently by giving it some different experiences. And those experiences are what happens if you let yourself experience the thing you're scared of without doing a ritual or a compulsion, right? Now, it's a great treatment. It works really well. There are many, many clinical trials, and it can be a hard sell because if you're reading between the lines, if you're a parent, you're probably thinking, but that would make my child so anxious and stressed out. Yes, and that's nothing to be frightened of, right? Because
Ex-
facing that anxiety is exactly the first and right thing to do, right? To
Even though it sounds
support.
so paradoxical, right? I mean, you have
Sounds
to
so
embrace the
paradoxical.
uncertainty to get through it, don't you?
Right. And I want to kind of step back for a second and also say, if you're a parent listening going, oh my gosh, but I don't, I actually don't do that at all. And I want to minimize my child's anxiety. Of course you do. I mean, we all do as parents. And in this particular case, unfortunately, even though it seems like that makes the most sense and we all start by doing it, it's counterproductive, right?
And Lisa, explain to us briefly why that is counterproductive. What's happening in the OCD cycle if I, as a parent, in a very natural way, want to assuage the concerns that my child might have and I provide reassurance? What might I be inadvertently doing with that OCD cycle?
So two things happen, right? And this is tough for parents sometimes to take in, and I'm going to encourage folks to really listen. Is number one, it reinforces your child's idea that they cannot handle their anxiety, that it's a dangerous emotion, that it's something that they just can't learn to do, right? Number two is it takes away from them a really important learning opportunity where they can learn and touch their own strength and their own ability to handle this stuff. And really, the mastery that they can achieve about this and how they feel after they get through treatment is amazing. They're so proud of themselves, right? They've done these hard things and that they didn't think they could ever do, right? And so working with providers who are well trained in this, what you should look for is the use of exposure and response prevention and their ability to answer you, if you are a parent, all of your questions about this and support you. And how do you face your own anxiety of doing this treatment, which feels so counterintuitive and paradoxical, right? How do you actually support your child through that too, um, without feeling like you're just causing them stress for no reason? So there's a lot of different pieces to this, and it is absolutely worth doing.
So, Lisa, you mentioned ERP, exposure and response prevention. Are there other approaches, other therapies, other layers that are used when treating kids?
Absolutely. And one of my favorites is acceptance and commitment therapy, which is also an exposure-based treatment. It involves creating more space and willingness to experience uncomfortable emotions and thoughts and response prevention. And what they do for that is, in addition to that, is to help kids tune into what are the things that really matter to you in your life. What do you want to be doing more of that you really love, that makes you feel alive and vital? And it might be things like connecting with my friends or being good at sports or being a good student or going on camping adventure, whatever it is, right? And engaging in those valued activities absolutely is going to bring kids in the presence of the things that trigger their OCD. And so what you what happens is they come to a choice point. Either I can give in to my OCD and let it send me running where my life feels pretty small and airless and I don't get to do the things I really love to do, or I can face my fear, make space, and do these things that I care about and see what happens after that. And the more you can help kids engage in those things that are valued actions, the more self-efficacy they tend to grow and attain. So it's a really, that approach also has an evidence base with OCD, and it's often used in conjunction with ERP as well.
What should we know about the use of medications with kids
I'm
and teens?
so glad you asked because I was thinking I should probably tell them about medication. So, medication is also an option, and there is an evidence base for things like SSRIs, especially when used in combination with the behavioral treatments. So, I'm going to say a couple things about this. Number one, if you have a choice, I hope you start with the behavioral treatments because one way or another, and teens, it's important that they learn how to relate to these scary obsessions or mental experiences differently than through avoiding them, right? Medication is helpful because it's kind of like training wheels on a bicycle. It might make things easier at the beginning of treatment, which helps kids engage in treatment, right? Or if you start the behavioral treatment and you're a few weeks in and you're not seeing any traction, um, that might be a time to talk to a provider to see if you want to augment that behavioral treatment with medication. The other thing is that medication over time is not supposed to be a long-term tool. And unfortunately, we see a lot of kids and teens that are on it, but there are no really solid longitudinal data about the effects of these meds on growing brains. And so we really do want to think about, can we start with the behavioral treatment first, right? Now, there are some cases where if you have no access to that and you have an absolutely unwilling child who doesn't want to engage, you might start with meds, right? And what I would suggest is go to a trained psychiatrist that has experience with OCD rather than a pediatrician, because there are some dosing differences across, for example, the thing that SSRIs are typically used for mood disorders and OCD, and also across children and adults. So it's really important that you go to a provider, if you can, who is familiar and conversant with dosing for OCD in kids and teens.
Lisa, what should we know about the level of care options out there? Can most of this be done outpatient? Are there times when a child might work with a residential program?
Yes and yes. So for kids who are willing to get treatment and for parents who have resources to bring them every week and can support their continued engagement outside of session in the practice, right, of exposure and response prevention, outpatient treatment is a it's a great tool. And so I want to circle back and highlight that this is not a treatment where you go once a week and then you do nothing all week and then you go
Mm.
back to your therapist. This treatment requires practice of what you learn in sessions outside of those sessions every single week. And so that's a really important tool. Now, if you have kids who have tried outpatient treatment and or medication and they haven't made traction, perhaps because there's a lot of reasons for this. It could be comorbid conditions are making things difficult. It could be that they just are unwilling to do it, or it's really hard, or they need added support. There are other levels of care from intensive outpatient programs, which are more than one time a week, usually two or more, or partial hospitalization programs, which are even more than that. And those include day treatment for OCD in a setting, again, ideally that is specifically tailored to OCD sufferers, not just a general partial hospitalization program. And at the very most extreme end, for kids who really, really, really are impaired, who are at the most extreme level of severity, you might look into residential level care, which is at a residential treatment center. Again, it should be specifically focused on OCD because general residential programs do not treat OCD. Okay, not well. And you really need a specific kind of milieu to really maximize the benefits of those programs. And they can last anywhere from, it really depends. There's a huge range, but I would say on average about 3 months. of residential care is really, really helpful and worth doing for some kids.
Couple questions for you here on this front. You have worked with numerous kids and teens over the years in your practice. What
Mhm.
are some of the upsides and additional challenges of working with a child? I mean, I've heard, for example, that children can be quicker to make some changes that adults are reluctant to make, but I imagine they bring their own challenges as well. So what comes to mind for you on that front?
Ah, I love working with kids. That's a good question, actually. I would say treatment is different with kids because we have to think about things like, for example, understanding that there may be a different pattern of comorbidity in children and teens than in adults. For example, teens with OCD are, I think, 7 times more likely to also have comorbid depression than children with OCD. So that's something to notice. You might see more disruptive behavior disorders in addition to OCD in younger children. Things like ADHD or tic disorders or Tourette's are sometimes comorbid. Um, there's a huge overlap in children, as in adults, in if you have a child who is autistic, they have a much higher likelihood. They're actually 13, folks with OCD are 13 times more likely to have or to be autistic persons compared to the general population. 1 in 5 kids with OCD also have ADHD. So that's really important to know. With kids, it's engaging them and making treatment fun is really important. Making it concrete is important. Checking in with their social and emotional skills prior to treatment is also important. For example, if you have kids who are not great at naming or their emotions or labeling them accurately, if they have limited emotion competence, you might want to work on that first. Otherwise, how are you going to teach them how to make a symptom hierarchy, right? Of ERP activities that they're going to engage in. If they're not great at gauging changes in the intensity of their discomfort or their anxiety. So that's really important. Thinking about issues like of belongingness in teens is very important because you have OCD in context and they might not want to tell any of their friends because they fear social rejection or they fear being weird or left out or ostracized. And so that, of course, limits your social support that you can have from people. So, really thinking through what is the school situation like and can we support there? How do we engage teachers as, not necessarily part of the treatment team, but as allies and supporters and advocates? Um, and how do we help them understand that, you know, accommodations in terms of OCD in the classroom can sometimes be useful, but sometimes can actually be counterproductive. When you want kids to be able to handle the OCD and learn how to face it in a way that doesn't make it easier for the OCD to continue sticking around. So, and then the last thing I'll say is work with parents, right? OCD is interpersonal. And when you have someone in your family, i.e., a child or teen, it can impact all family members from siblings to parents. And understanding how do you best support this child without invalidating them and without feeding the OCD is something that's really, really important to consider and is a big difference for child and teen cases than with most adult cases. Although sometimes that's true for those too.
I want to dive deeper on a couple of things that you brought up. We'll get back to teachers and the classroom in a moment here. But in terms of parents, do you bring them into the treatment process? I mean, more than just having them drop off their kids for a session. Are they
Yes.
actively involved in the treatment process? And what might that look like?
Ideally, yes, yes, and yes. So you are more likely to see this in younger children and less likely in adolescents. But I want to say to parents of teens, it is equally important to be engaged. So the very basic would mean educating yourself and learning all you can about what is OCD, how does it work, how is it likely to affect my child, and how is it likely to affect my family? And what things can I do to help rather than hinder treatment? So that's number one. With parents of younger children, we usually want to engage them as supporters of exposure and response prevention practice outside of session. And they might help by putting those stars in the behavior chart every time they notice their child practicing ERP, and then rewarding them at the end of the week with something that's a feasible and sustainable reward that fits within their family, right? Doesn't have to be monetary. It could be something like the kiddo gets to choose their favorite meal or have a play date with their friend or from some special time with mom and dad. Um, so really engaging them as exposure coaches for their kids. With parents of teenagers, it's more about changing communication patterns around OCD to make sure that they're validating and supportive and empathic, and also expressing confidence in the teen's ability to get through their OCD, to engage in treatment, and to beat the OCD, right? So it's a more collaborative process, and it involves also reducing here's this word again, accommodations.
Mhm.
And when we think about accommodations from a family perspective, what we mean is when parents change their behavior to reduce anxiety or discomfort for their child, while that feels like the right thing to do in the moment, it can often be counterproductive. And so pulling back on accommodating and increasing what we call autonomy granting, which means giving your child appropriately more opportunities to learn how to handle this on their own, right? Those are key pieces of parent involvement in teen cases.
One more question on the family front, and this would be an entirely different session, so we don't need to go too deep into it right here. But what about the family dynamics? I mean, I'm imagining that siblings can be impacted by a sibling
Mhm.
with an OCD challenge, for example.
Yes, in many ways. And so there's 100 different ways to think about this. For example, parents sometimes feel like all of their resources are going to the OCD sufferer if they're and not to if they have a more typical child who's not struggling with OCD. Another way this can play out is there is a kind of OCD presentation called emotional contamination, where the sufferer can feel like they might be contaminated by aspects of another member of the family that they don't want, right? So if it's a brother or sister and they think that that brother and sister is bossy, for example, they're going to become inappropriately bossy. So they don't want to have anything to do with that brother and sister. Another way is in terms of moral scrupulosity, presentations of OCD, where kids can be very, very upset when there isn't fairness and rules aren't followed. And you can see many conflicts arise with siblings around that one. You can only imagine. And then the parents are stuck trying to figure out what the heck is going on here. So there's lots of different ways OCD can present with siblings as well. Those are just a few.
Let's circle back to teachers and the classroom. This is such an important part of any discussion
Mm,
involving kids and teens and OCD, because kids spend a lot of their time in a classroom. You
exactly.
touched on this before. How might parents work with their teachers, the kids' teachers, and the school system itself to help be part of the team approach to addressing a child's OCD?
Right. And so behind this is a discussion about, do we share our child's diagnosis with teachers? And that's going to be an individual family by family decision. If you feel like it's helpful and you have a supportive school environment and willing teachers, it's a great idea, right? Because it's an educational opportunity for them. It's a great opportunity for them to help figure out how to support your child in the classroom. But if you have an adversarial relationship with a school who doesn't have a lot of resources, or there's some unwillingness to really address this, it can be a decision that's hard for parents to make. And so you might want to think about, instead of giving a label, thinking about what does my child need and how can I work on improving this relationship with the school and teacher such that I can get those needs met. So it's important to say that 1 to 2% of kids, or about 1 in 200 kids, have OCD, which means about 4 to 5 kids in an elementary school, average size elementary school in the US, and about 20 in a high school, right? In the
Mm,
average size high school. Um, it is, the mean onset for in childhood is 9 to 11 in boys and 11 to 13 in girls. And at at those ages, it's more common in boys, um, but the rates even out as you grow into adulthood. So OCD is in schools. It is there. And teachers might miss it because it's not something that they will know to look for. Or know what to do with. So I would say, thinking from the perspective of, if you're a parent, how do I create a good, solid relationship with my child's teacher? And how do I, from the context of that relationship, talk about what might be helpful, right? So sometimes helpful mean things like not giving them an extension on an assignment when it's easier to do so. Sometimes it will mean the opposite. So it really depends. But I would say having a good relationship for your with your teachers is important. And a resource you can actually send to your teachers is the Anxiety in Schools portion of the International OCD Foundation website, which was designed with expressly this in mind. So there's a resource out there that's free. You can just access right now. Look at it, see if it's useful, see if it's going to be helpful, and you could share some or all of it with your child's school or teachers.
yeah. It is an amazing resource there. And I think it makes sense to take just a minute or two and talk about some of the ways that OCD can manifest for a child or a teen in the classroom. The one that always comes up for me is that oftentimes a child might be thought to be missing some of the educational aspects of their classroom work because they
Hmm.
can't finish a test. When
Exactly. Yeah.
in reality, it might be that that child needs to line up their papers and their pencil perfect before they can start the test,
Hmm.
and therefore they can't finish it for those means. That can get confusing for teachers and
So,
educators trying to suss out what's what.
yeah. And I think that's a great opportunity for parents to talk to the teachers. And if you're a teacher listening to this, to check in with the parents to say, hey, I'm seeing this. Do you know what's going on here? Because it can look like an executive functioning deficit when in fact it might not be that at all. It might be something else. Kids might be engaging in cognitive rituals in their head. There's a form of OCD that we sometimes call need to know, where kids feel, or adults feel, like they have to, when they're reading, glean every bit of information perfectly from a test or text, which leads them to do the ritual of rereading multiple times slowly. If they get interrupted, they have to read a sentence again. And that can get in the way of learning, right? It can get in the way of doing tests, things like that. You might see kids who ask repeatedly to leave the room to go use the bathroom, to check something, to wash something, etc. It can be, there's 100 different things that could mean. Or perhaps there's a peer in the classroom and some emotional contamination with that peer. So they're trying to avoid that peer. They don't want to sit near them or something like that. And that might look like oppositionality. And so it's really tough to detect. And being willing to have conversations with families, and also to check out that IOCDF website, can be great options to learn more.
So, in your practice, in representing the field, if you will, for just a moment here, do you sometimes work with a sort of a team approach and talk both with parents and teachers, for example, for how they might help implement a child's plan for recovery?
I frequently talk with parents, and I wish I could talk more with teachers. I love also working with teachers. And sometimes families are very proactive in saying, could you talk to my child's teacher? Or what could this teacher do? Or can you give them resources? We also, in my clinic, we not just do treatment, but we do consultation and training of schools, of teachers, of whole clinics, of individual clinicians who treat this, because it's just something we're really passionate about. So I would say, yeah, it's really important to do that.
Let's move next to clinicians who might be in the audience right now. And they might be more of a generalist in terms of their approach of dealing with various childhood and teen mental health conditions. Um, where might you point them for additional training in how to address OCD and any other guidance you might give them in terms of working with specialists?
Yeah, so the International OCD Foundation has what they call the Behavior Therapy Training Institute, and they have a specific pediatric BTTI, as it's known. Now, there's a fairly long wait list for this, unfortunately, but it's great to get on it. But there are other options to find really good consultation and training. There is a new program called Menti, the mental health, I'm trying to think what it stands for, treatment network, basically. And they have experts that they have called in who are vetted, who have been doing this for many years, and where you can watch a training, you can get your CEs. It's a really wonderful program. And then the other thing to do for treatment providers is to many of us who have been in the field for a long time do consultation, right? And there are lots of options for that. And I would highly suggest not just doing a training, but having ongoing consultation if you want to make this a really solid part of your practice. Meet other clinicians who do this, get in either a peer consultation group, some of those are free, some of them are paid, but either way, get involved and learn from the clinicians around you with more experience, get their tips and tricks. Um, that can help you cope with these cases that are sometimes very challenging and complicated.
Speaking of which, let's circle back to the co-occurrence challenges. It sounds like that's a pretty common challenge for teens and kids with OCD, that they might be
Yes.
challenged by something co-occurring. How do you tease out what's what as a clinician? And as a parent, these are separate questions. As a parent, how might you take on a team approach that addresses both without robbing one or the other?
Right. So, as a clinician, we use evidence-based broadband diagnostic measures like the Diamond, which was a measure developed by David Tolan. They have one for adults. They also have one for children. And what I love about this is it's an evidence-based structured clinical interview that touches on OCD and other, body focused repetitive behaviors, other disorders like that, also mood and anxiety disorders, as well as things like PTSD, substance use, and eating disorders, etc. So it really runs the gamut. And the reason it's important to kind of take a broad look at what's going on because comorbidity and OCD at any age is really the rule rather than the exception. Um, the second thing I like about the Diamond is that it has it has parent and child screeners. So if the child is old enough, they can self-report on what they're experiencing. And if they're young, you can also ask a parent, which is essential. You can still do this with parents of teenagers, also very important. So I would say use those, use the Y box, which is, or the CY box, which is the Child Yale Brown Obsessive Compulsive Scale, which is a structured clinical interview, not just a paper and pencil measure that gets at the full gamut of types of obsessions, the full gamut of rituals, as well as it gets at the functional impairment and distress that causes. So you get a level and a sense of the severity of the disorder. So those are all really important to look at all of those things. For parents, what I would say is make sure when you seek a treatment provider, they are skillful and knowledgeable at treating OCD. And there are a few questions you might consider asking, right? Number one, do they do exposure and response prevention? If they don't know what that is, this is not the treatment provider for you, right? If they say, oh, yeah, I do CBT, no. Do you do exposure and response prevention? Because a lot of providers will say they treat OCD and think that they do because they know CBT, but You want someone who's specially trained if at all possible. You also want to ask them, how do you diagnose OCD? If they just tell you, well, we talk,
Mhm.
that's not enough. You want an evidence-based assessment process for that. Third question, what percentage of your practice is about treating OCD, right? I would say look for somebody who does at least 50%. If
Mhm.
they're like, oh, I've had a few cases here and there, that's not going to be sufficient, right? And you really do want someone who knows their way around doing this stuff. If you do that, you're going to be in good hands. And again, go back to the IOCDF website, iocdf.org, and you can learn a lot more about how to find a good provider, and also see their provider directory. You can type in your zip code and they'll send you to who's in the area, who has training that's been
And,
vetted.
and Lisa, just to make this one more step complex, what if I, as a parent, have learned that my child has both ADHD and OCD,
Mhm.
and we're looking at separate specialists? How do you coordinate all that?
I would just interview the provider and see if they have experience with both, because that's a really common presentation.
Mm.
Are they aware of how ADHD or an executive functioning deficit will impact how you might actually implement exposure and response prevention treatment? And most of us who have been working with children for a while know how to do that. So it's a good idea to make sure that you know from your provider which of those conditions is primary or more prominent. Where do we start? Because if you have a little one who can't sit still and has difficulty encoding information, say, because they're inattentive, it's going to be tough to get them to engage in ERP, perhaps, or remember to do it when they go home. And so you're also going to want to make sure that that provider can give you, as a parent, supports around that. Another way that this is important to consider, for example, is that parents who have children with ADHD are more likely to struggle with depression than parents of more typically developing kids. And so, is this provider skillful um, in supporting you at with that, should you need it, or can they refer you for your own treatment, should that be helpful to you? In the middle of while you're trying to work with your child with OCD and ADHD.
Lisa, I want to bring this session full circle and speak for a moment or two here about the importance of addressing OCD early. I
Mm,
imagine that some parents might fall into a trap of thinking, my kid's got enough on his or her plate. Let's
yeah.
let this play out and we'll address it down the road. Why is it so important to tackle OCD as soon as it's recognized?
Well, number one, kids don't grow out of it. It's not the kind of thing where it shows up and then it disappears. And number two is the younger they get it and the longer it goes untreated, the more severe and profound the cascading, developmental effects are, where you have a child who might have difficulty with academics, with peers, maybe there's a lot of family conflict. And the longer that goes on, the more those situations compound, and your child is going to start to fall off that developmental trajectory that they should be on. So, don't wait. It's really hard to find treatment providers that are trained well in treating OCD, number one. But number two, the effects of not getting treatment are just so, they're so pernicious. So I would say, please get it checked out if you think it's going on. Worst comes to worst, it's not OCD and you've just done your due diligence. But if you are noticing it and you catch it early, your child is going to be in a much better place later on in their life.
Wow, Lisa, we have covered a lot of ground over this session, and I want to thank you again for making time to share with us all this wisdom about OCD in kids and teens. Thanks so much for your time.
My pleasure. Always happy to be here with you, Jeff.
Dr. Lisa Coyne. And to those of you watching, thank you for your interest in our Deconstructing Stigma video series. We hope you'll come back for our future sessions, and we wish you a wonderful day.